Well, welcome everyone. I'd like to call to order the Board of Health special meeting today, August 20th. And glad to see everybody here. We weren't able to do our July meeting, had to reschedule for today. So glad that we have our board, almost a full complement of our board here. So let's start with a roll call. Why don't we just go around the room and introduce ourselves? So I'm Commissioner Amber Waldrop, Spokane County. Commissioner Kearns.
Josh Kearns, Spokane County Commissioner.
Mary Cuny, Spokane County Commissioner.
Dr. Velasquez, Health Officer.
Alicia Thompson, Administrative Officer.
Charlie Duranona, representing community stakeholder.
Michael Cathcart, representing cities and towns.
Patricia Keenholtz, representing public health consumers. Michelle Fossum, legal counsel.
Ann Pittsnoggle, recording secretary.
And Dr. Blakowski-May, can you hear us okay?
Yes, I can hear you, and I'm here.
Okay, great. Excellent. And maybe this is Liz. We have a new board member joining us, Liz Henry. We just went around and did introductions. If you want to introduce yourself, we'd love to know a little more about you, so welcome. That's okay. I'm glad you made it. Yes, there is a lot going on today, so I'm glad you made it.
My name's Liz Henry. I am the healthcare administrator for the Kalispell's Kama Center Clinic. I've been in healthcare for most of my career. I work for the Indian Health Service and several different tribes, and currently I'm serving for the Kalispell tribe.
Welcome. We're glad to have you here, and sorry that you're just jumping in first thing, but we're glad to have you, and we'll get going with our agenda. So we just did the roll call, and do we have anyone signed up for citizen input?
There's no one signed up.
Okay. Anyone online? No? Okay. Then we'll just go into board reports. So as of a chair report, I guess basically it's been a great summer, but we haven't met since the end of June. And so we did have an executive committee meeting in July, and then we ended up rescheduling the meeting because we weren't sure we'd have a quorum at the end of July. So thanks to everybody for working with Ann to find a magic 2 hours when we could all be here together. So that was basically what we've been working on from the chair's perspective. We've been working on the budget process and what that looks like with Kim and Alicia. And so I know we'll talk more about that today, kind of over the next several months. So we have lots of touches on the budget as a board. So that's probably what we've been focusing on the last couple months. And committee reports. Commissioner, it seems like it's been a while since we had our committee meetings.
Well, we met July 17th prior to the executive committee meeting. So we'll, again, looking at vouchers, reviewing that, doing all of that, the normal things. And then I think we'll be, talking about the budget as we move forward now. So it's busy times for budget season for all.
Was there a meeting of the health and education committee? Policy committee?
No, there hasn't been anything with the logistical shuffling. There hasn't been any.
Welcome back. Councilman Cathcart was off, now he's back on. So glad to have you back. And I think today we're going to consider our bylaws change to make sure we're all up to speed with the new RCW that was passed that kind of changes the way we add tribal members and elected members to the board. So we had an update on that back in June, and we have our first appointment by the Kalispell tribe, and we may have other appointments. And so we'll walk through that process a little bit today. Okay. So first item then is our consent agenda, and it includes the meeting minutes from June 26th meeting, the vouchers for the month of June, several interlocal agreements, and a contract with NetSmart Technologies. And I believe that is the new company that took over the other company that is handling our opioid treatment medical records program, right? Okay. So does anyone need any briefing on these items before we look for a motion? Yes, Councilman Cathcart.
Yeah, I'm curious about the interlocal, the opioid remediation, what that means. I haven't had a chance
So
to.
item 5E, and I believe this is some of the City of the Valley's opioid settlement dollars and contributing that to the health district. Do we have a little synopsis of that, Alicia, Dr. Thompson? Oh, no, on 5E, is that the Valley contributing some of their opioid settlement dollars with the health district?
Sorry, and with the data center, providing them with-
Tracking and providing more specific data
for
for
the Spokane Valley.
opioid issues
Yes.
in the Valley.
Exactly.
Okay.
All right. So if there's any other questions, we can take those, or I can look for a motion to approve the consent agenda as presented. I think that the Board of Commissioners we were briefed on the child fatality. Those are agreements that come through our medical examiner. Yes.
I will so move the consent agenda.
I'll second the motion.
Okay, we have a motion and second to approve the consent agenda, items 5A through F. Any discussion on the motion? Okay, all in favor, say aye.
Aye.
Aye. Any opposed?
Aye.
Okay, we've unanimously approved the consent agenda. So moving on to number 6 on our agenda is the administrative officer, Alicia Thompson, and your report.
Thank you. And the first is just a reminder of our exits, where our exits are and where our restrooms are in comparison to where we are in the auditorium. And welcome, everyone. We're going to talk about the staff kudos, the barbecue, the annual barbecue that's coming up, the budget, the 1946 law and board composition, a building update, and then the treatment services update. So, staff kudos. And just a reminder, so we have quite a few kudos that come in every quarter, and the staff then vote on the top 3 that want to be brought to the Board of Health. And so these are the kudos that the employees of SRHD wanted to make sure the Board of Health was aware of. So Forrest Birchnall, he is always willing to help and has assisted this individual who submitted them many times in setting up my new Surface Pro. Thank you, Forrest. And Forrest is very helpful with everyone. Then we have Steve Heidel. Steve is always willing to help the WIC team with a smile on his face. Even when there's a lot to be done, we appreciate all he does for our program. And then IT overall, and you're going to see them presenting a little bit later. Recently, IT upgraded the phone system and integrated a brand new communication switch. While we don't usually think about IT unless we have a problem, they are always behind the scenes, keeping our systems running and secure to support the work we do in the community. Thank you to the entire IT team. So thank you to all who submit kudos and who have received the kudos. Okay, so the next item, is our barbecue. Want to remind the board that we are having our annual barbecue on September 16th from 11:30 to 1:30. We're going to have live music by Daniel Hall. We're going to have games and fun. We're going to have barbecue, and we're also going to have the years of service ceremony at our annual barbecue. So we would love to have any of you attend that are able and be a part of that fun day. It's our one day a year where we get everyone together and just have a good time. Excuse me. Okay, so next up is, I'm sure most of the board is aware that the county has requested SRHD to reduce our budget by $500,000 to $1 million. And that is a significant cut for us, but I want to give kudos to our entire team because everyone worked diligently on their budgets, and we were able to, like if it was a normal year, we were able to reduce our budgets down to what would be an ask of a little over $1.6 million, just by really taking a hard look at our budgets and reducing it to that amount. And so to reach that request for a reduction of 500,000, we just have to find another 122,000 to bring it down to an ask of the county for the 1.5 million. And we are working right now to identify different possibilities for how we could bring that down even further to a $1 million ask of the county. And that will be presented in September at September's board meeting. And just a reminder that SRHD has basically three discretionary funding streams. One of those is from the county. The other is the local government assistance fund from the state. And the third is what's called reinforcing capacity dollars from the Foundation of Public Health Services. And that amount we're allowed to use as needed in our organization. All the rest of our funding is either categorical, meaning we have contracts, statements of work that we're required to provide, and then we have our indirect. So just wanted to remind everyone of that. And so, as I mentioned, they have done, the whole team has done a fabulous job of reducing their budgets. And we will be coming in with the scenarios that will achieve the goal of what Spokane County has asked us of in September. And so we'll have a few different ways we can meet that. The reducing it down to a 1.5 million at this point is going to be really fairly easy because of the amazing work that the team did already bringing it down to 1.6. So it will just be that another cut down to the $1 million ask. So do you have any questions about that?
Alicia, on the last slide, you said discretionary funds account for approximately 11%.
Yes.
The county portion that we fund the health district, that's all discretionary, correct?
Mm-hmm.
So what amount is the county funds of the overall discretionary funds of the agency?
The percentage?
Yeah.
Um,
So I guess
It's
of,
about
of
30
the 11%,
It's
how much
about
of that?
33% because the other two discretionary funds are right around just over $2 million
So
themselves.
So 4% of the overall spending then, or overall
Something like
agency
that.
budget?
Yeah,
4%.
something
Okay.
like that.
Okay, and I just will highlight, we've asked each of our county departments to look at cutting at 7%. So just kind of for comparison, just kind of.
And I
compare
can
apples
see
to apples.
Kim has gotten her phone out. She's got her calculator going. And so when she comes up to give the finance report, I'm sure she's going to be ready to give you those exact percentages. Yes.
Sounds great.
Yeah. Okay, any other questions?
So the plan is just to lay out the budget process. The plan is to have 2 Budget and Finance Committee meetings in the
Yes.
month of September prior to our September board meeting, where the full board can look at different scenarios and discuss, right?
I'm going to let Kim
Kim will walk
answer
through
that
that.
question
Okay.
because we typically have 2 touches of the full board on the budget. One is in September, the second is in
Right,
October.
right. Okay, we'll let Kim walk through that
Yeah.
and we can give feedback if anybody has ideas if we want to change that up. But we want to have a lot of touches and look at it. I think, my concern is like when we at the county, we've been trying to look at a multi-year, projection and try and manage because the things you do this year can then impact next year. And so, one request I would have is just looking at least at a 2-year. And I know that's maybe hard. 'Cause
forecast.
you always have like employee contracts that you're negotiating and you can't exactly know, but just at least forecasting in the next 2 years. Because I get concerned about some of the changes at the federal level too, and we don't know what those are all going to be, but we should probably be planning for like a 2-year budget cycle and making appropriate changes this year. But then anticipating what changes we might need to make for 27 as well. So anyway, sorry, I'm jumping ahead to Kim's budget and finance update. So thank you.
So I just,
Yes, Commissioner
so I just want to clarify. So you're saying everyone's worked diligent to get to the $500,000.
Well, they've gotten it down to a little over $1.6 million. And now we're looking, okay, everybody feels like they've cut their budgets as much as possible.
So when you say I just wanted to clarify. So when you say 1.6, you got it of the 2 million down
Yes.
to just,
Yeah, just
so
the Spokane
$400,000 reduction.
Yes.
Okay.
Yeah.
Thank you.
Yes. Okay, and so yes. Any other questions? Okay, then just talk a little bit more about the board composition. And so this is a slide that you've seen before, just goes over the law, the new law about having our tribal partners join the board, which we're very thankful that Liz Henry from the Kalispel tribe was able to join us like today, and that Councilman Cathcart was able to join us today, just like with 24 hours notice. I really, really appreciate that as your administrative officer. And then, so with this change that went into effect July 27th, the county did pass the resolution that aligned with the law, and our board bylaws are being updated today by the board, so that our bylaws are in alignment with the changes to the board composition. And then it is important to know that tribes aren't required by law to have a representative. They have an opportunity to have a representative. And I have spoken and reached out to both the Kalispel and the Spokane tribes, and as well as Native Project and the Healing Lodge of the Seven Nations, because those are the 4 organizations right now that are currently eligible. I did see some news about the possibility of the Coeur d'Alene tribe eventually becoming eligible. So one of the important things that happens is that after a tribal representative has been made, or they've made the board, I'm the secretary of the board, so they make me aware of their representative. Then we notify the American Indian Health Commissioner, and we have 60 days actually to have them join the board. What is really important about this process is at the same time that a tribal member joins the board, we also have to have the elected official join the board at the same time. That's why we have Councilman Cathcart back today, and Liz Henry has joined the board. And so for every time we have a tribal member join the board, then we will also have an elected official join the board on that same day that they come on board. And so this just outlines how it happens. So we have our first tribal representative, and Councilman Cathcart came back. The next time we have a tribal representative come onto the board, then we're going to add a fourth county commissioner. We have a third tribal representative. We're going to add the fifth county commissioner. And then add a fourth tribal representative. We'll add a second city or small towns council person. And we'll just continue with that as we, like if the Coeur d'Alene tribe becomes eligible and we have 5 tribal representatives on the board, then we will add another city or small town council person. Does that make sense? Any questions about that? Okay. Okay, yes.
Mr. Kearns?
I did have a bullet, or a question as to your last bullet on there, where it says they have to join at the same meeting. What if we're under a situation where calendars don't allow one of the individuals to attend? So like as today, if Ms. Henry or Councilmember Cathcart wasn't able to attend today, does that block the other individual from attending the meeting? And if so, where is that in the RCW or the bylaw?
I believe that's going to be a legal question.
So we need to make, the appointments onto the board. It's not required that they be physically present because board members miss from time to time. But so as long as we have appointed the right people onto the board, then we're in compliance with the law as I understand it.
Thank you.
And then I'm just going to clarify, we're kind of doing this as best we can with everything because we don't have the WACs associated with the RCW yet. So things could potentially change if the WACs.
That's
Adjust.
true because the statute went into effect July 27th. The Washington State Board of Health is tasked with developing regulations under the Washington Administrative Code to kind of fill in some of the blanks. And then, of course, they haven't had time to finish that process yet. So as they get that done, that may impact our understanding of the law.
Yeah, I think that's where we're trying to do the best we can at this point in time, but it could change based on what the WACs actually end up doing. So
Right. And just
if we see a change come forward, that could be why.
correct, right. And also important to clarify that the Board of County Commissioners makes these appointments to the Board of Health. The Board of Health doesn't make the appointments themselves. So we're talking about we make these and we do this, but it's really Board of County
Well,
Commissioners.
except the tribal
not the
members.
tribal.
Yeah, just the elected members.
Correct.
Okay.
And we have been in communication closely with the State Board of Health because we are kind of the pilot community that has really moved forward fast on this. And so we're providing them with all of the steps that we're taking and how it's working and that. So, okay.
So just so to clarify then, if they have a new process that they decide that where they're interpreting the RCW a little differently, we may have to update our bylaws here, and then the county may have to slightly alter our process. But right now, we're just going by what was written and updated in RCW as best we can.
Correct. And one of those key differences you notice on this slide, the next to the last bullet, previously we had said that the tribe would notify the American Indian Health Commission, and then the State Board of Health reached out to me and let me know that it's actually the Board of Health that needs to notify the American Indian Health Commission. And as the secretary of the board, I reached out and notified them, even though Liz had already CC'd Vicki Lowe. And so.
So today we will update our bylaws to make it more clear
Yes.
that you, as our designee, can do that.
Well, that's your decision.
Right.
That's your decision.
Okay.
Yeah.
Just curious on the last bullet, since it's really not up to us, what does it mean exactly for 60 days to have them join? Does that just mean they get appointed, and if they don't show up for 60 days, somehow they're no longer appointed, or what does that mean?
Well, again, we don't have the wax. My interpretation is that from the date that we're notified by the tribe, that, for example, and Liz, I hope you're okay with me using you as the example. So we got notified on Friday of last week that Liz was the representative for the Kalispel tribe. And from that date of notification, we have 60 days to get all of these other things, like who's going to be, when it comes down to when we add other city or small towns, we have 60 days to identify who that is going to be. With county commissioners, and I believe that is in the law, the current law. I don't have the full law here, sorry, I apologize. Anyway, the law does say we have 60 days once a tribal member has been identified as wanting to join the board.
Yeah, I think
Yes.
it's more related to the Board of Commissioners. So once you receive notification from a tribe or a tribal health organization, then it kind of, and then word is given to the Indian Health Commission. Then there's like a 60-day clock for the Board of County Commissioners to make the elected appointment.
Yes.
At least that's the way it's written until there's a new WAC.
Yes, yes,
Yep. And I was going to make that point as well. That's just the stopgap until the state Department of Health finishes the wax. And then we'll have a more formalized process, we hope.
yeah.
Yeah, I don't know if that makes sense like mud, but that's what's in the RCW.
So, and this is the current process that we had talked about previously. And of course, if the Board of Health wants to change that process, we'll be more than happy to do it. And that comes to me being the board's secretary. And that's why I had me as the person to be contacted with the tribal member information. So, okay. So moving on, building update. Very exciting. Has anyone noticed driving up to the building how white and beautiful it is? It's not just white and beautiful, it's also stable. All of the bricks that had unstable mortar and were at risk of falling out and has been repaired. And so it's Lola and her team have done a fabulous job on getting this project done, and they are targeting Friday for being done and having all their equipment off site. And so the building will be sealed. All of that mortar and brick will have the sealant put on it. And then Lola is working to ensure that we have the ongoing rotation of having the building sealed, have that sealant put on the brick so that we don't ever get into this situation again where the mortar starts falling apart, basically. Any questions about that? And Lola is here if you want to ask her any questions about it. Okay. And then the treatment services update. Misty and Adam, do you want to come up?
Okay. Good afternoon. Okay, so at the end of June, we had over a 339,500 surplus. And moving forward, our numbers at the end of June. So this is because we didn't have our July meeting. These numbers were reflective from June's end of month totals. So end of year 2025, unique individuals served was 1123. Courtesy dosing was 158. Methadone and buprenorphine doses dispensed. You can see the large numbers ever increasing there at the end. Sorry, I went to dispensing versus intakes there first. And the days from referral to admit is still under 2 on average. So again, just to recap, that number just means that when an individual comes in, if they can't get in that same day, then the number of days that it takes for them to come back and get into services, whether it's scheduled or coming back in on a later date, is 1.5 on average. Turned away overall throughout the year has been 80. Number that has been turned away and returned for admission were 42, and a total number for the year transfers and or discharges was 257. Questions on that slide? No. I did you want me to go through that again? Yeah.
So the first question I have is the unique courtesy dosing patients. Is that number reflected in the number above the 1123, 1,123? So that you would add that on to that. Okay. And then the other question I had is the buprenorphine. Are those patients typically using methadone also, or are you just, okay, so those are my questions. Thanks.
Yeah. Okay. Wait. Nope. Go back.
Yeah, it has a delay. I should have warned you.
There we go. Okay. So our counseling numbers, year to date, for individual counseling, telehealth, group, and counselor assessments. Again, the individual counseling, we've got just over 4,100 for individual therapy sessions. Telehealth, 451. Group therapy, 643. Counselor assessments is 258. So that's 258 counselor assessments for the year. And jail doses, we have just over 4,100 doses that have been dispensed at the jail this year. And individual jail dosing and patients served is 103. And that now also shows that we have 14 intakes at the jail. Just as a side note, we have a counselor that has taken the position for our community spot, for our community counselor, and that position will now be able to more readily do assessments and intakes for the counselor portion at the jail. So that jail assessments, that number should be able to start being increased as the need is identified and appropriateness is identified as well. Questions?
So I guess just a question on that, the interaction with our mental health staff at the jail and our medical staff at the jail, because then we will be having a new medical treatment provider in going into 2026. So how is that working then?
So as of right now, there's not been any issues. There's not been any hiccups or issues that we've been informed of. We did have one minor communication, but that was worked out. As far as transitioning, it's as soon as we're made aware of that transition to the new medical provider, then we would work to have our teams work collaboratively with them, as well as ensuring that we have the necessary MOUs and documentation in place with that provider as well, and working with our contracts department.
The community counselor, is that position then more, they're able to get out in the community and do more assessments beyond the jail as well?
Correct.
Okay. So would that be working with like some of the outreach teams that are out there, meeting people where they're at on the street, or homeless individuals? Like what does the community counselor?
Potentially. There's actually a large need at the jail for admissions, but again, it's determining, kind of triaging the situation with each individual that's seeking services to ensure that the appropriateness and ensuring that the individual is not going to be going into prison for long term and not being able to continue to receive services and then ending up in a detox situation. The other piece is we have individuals that end up in hospitals in our community that are in need of services and can't quite get to us because they're hospitalized. So that's where that community position would be able to go to the hospital, go to our local community services such as Peer Spokane, and other partners as well to help meet the patients where they're at in order to do that first portion and help maybe with a bus pass to get to us for the medical portion of the intake.
So I get what you're saying, like just getting the assessment done, so it breaks down a barrier
Part of
for
that
them
barrier.
to then be able to access treatment, the
Absolutely.
medically assisted. Okay, thanks.
Absolutely. Any other questions? Okay. I'll do that way. And medical, so to that point of the medical portion, year to date, there's been 347 physicals, and the assessments, there's been 261 assessments. So that assessment for the medical is, again, to the counselor assessment. This is the medical portion to that. So anytime there's a new admission or a transfer from another program, the medical team has to do their portion as well. Okay. And I wanted to give an update on the expansion process. So we have had actually, since this, there's actually been more than one of the expansion positions have been filled. We've had a clinical assistant, an administrative assistant position filled. We also have a security position filled. We have the medical assistant is actually being filled, I believe, in the next 2 weeks. We have a couple of others that we're looking to have filled in the next couple of weeks as well. So the recruitment process is in full swing. Additionally, the clinical nurses worked incredibly diligent. They were wonderful. They actually came up with a plan and not only extended hours for, at the request of the board for that lunch hour, but they worked it out in their schedules to where they could make sure that it aligned with their collective bargaining agreement. And we are now dispensing until 1:30. So the doors stay open till 1:15 and they dose till 1:30. And then the nurses are, because there's less individuals coming in at that time, makes it a little easier to do the closing process, and they're able to get their steps wrapped up by 2 o'clock. So I wanted to give my own kudos to our clinical nurses because they did this of their own volition at the request of the board to make sure that this was able to happen. The second portion of that is that I wanted to share with you all is that effective on Saturday, September 6th, treatment services will be open on Saturdays from 7 a.m. till 10:15. And this is twofold. First part is it's a step in the direction of our expansion, but second of all, it was a requirement of the state that we have our Saturday hours available to patients for dispensing. This is the first step of the expansion into Saturdays. This does not include all services. This is strictly for dispensing. So this is just something that we are moving towards and will begin on Saturday, September 6th. Questions? Yes.
Is this a new requirement of the state?
No, we have had an expectation for some time. The state has worked with us because we had staffing issues for some time and trying to work to figure out how to balance that. And they've worked with us for a while, and they finally said, you know, we know that you're working on an expansion. We need you to go ahead and move forward with this. And we've been in communication with them.
Has the state offered any dollars in assistance? No.
Other programs around the state have had questions about how do we do this with staffing shortages, whether it's counselors, nursing, all the other pieces, and everyone kind of does it a little different. All programs have different requirements and different staffing structures. Okay. Any other questions?
Could you, just for the benefit of Ms. Henry, just explain the current hours and then the expansion that we're aiming
Of course.
to put into effect by what, November 1? Is that? Okay.
Yes. So treatment services has had our dispensing hours has been typically from 5:15 to 11:45. And then our business hours for counseling group and all other services has been from 6 till 2. And the expansion process is looking to make our dispensing from 5:15 till, I think, 5:15 to 5:30, 5:15 a.m. to 5:30. And that will give an extensive period of time for not only all individuals to come and dose, but for new intakes to come in, because that will not just be dispensing, that will be all services. And hence the need for all these additional positions for counseling, for medical assistants, for nurse practitioners, so that we can provide all wraparound services of an OTP for any individual in need that our community is still struggling in that opioid crisis. And we're making steps in that direction by expanding currently to the 1:15, 1:30 dispensing and the Saturday dosing hours at this point, and with the goal of this fall to be fully expanded. Of course.
And eventually the Saturday will go to
7 to 3. Full services.
from, sorry, what will be the hours?
7 to 3. 7 a.m. to 3
Okay,
p.m.
but you're just starting off in September was 7 to 10:15 or something. Okay,
Correct.
okay. Thank you.
All right. Thank you.
Welcome, Kim.
Good afternoon.
All things finance and budget.
Yes, and audit. Let's not forget audit.
Oh, your favorite topic. Your favorite topic.
Yeah, so good afternoon, and I will just segue right into the latest activities within the finance department. Is the state auditor's audit is underway. They started just after we filed our annual report with the state at the end of May. So they've been remote, which is standard these days, but they've been doing the federal single audit, looking at our WIC program and the COVID dollars that we received in 2024. They're also reviewing our financial statement presentation, and they're wrapping up both of those audits right now. And then they've started the accountability audit. So they're just starting that process. At the conclusion of the state auditor's office audits, they will have an exit conference. So all board members will be invited, and you'll be made aware of all the materials that follow. So we do need to avoid a quorum, but we'll make sure that you're aware. That should happen before the end of September. We also just recently had Washington Department of Health did a fiscal review, which is more of a program audit from the funder themselves. And so we get a lot of funding through Department of Health, and that was an expansive review that went through lots of documentation we provided, again, remote in advance, and then wrapped up some of the meetings with our program managers to answer some questions. And all indications is those have gone well. And we'll get some feedback as well as things that we can tighten up or do a little differently so that we can make sure that we have clean audits with the state auditor's office. So it's a real partnership with DOH when they have their program fiscal review, which is an annual occurrence. And then, of course, yes, we've been doing budget. Budget has started back in June when we were preparing the templates and the personnel schedules into our software system, push those out, the budget process to our program managers and directors in July, starting with our indirect programs to see what need we may have to determine our indirect rate that we would charge to the projects and the different programs. And then we pushed the budget process out to program managers and directors. August 11th was their deadline. And then now we are going through, myself and Dr. Thompson, with each of the divisions to go through each division and each program and project, literally line by line, and looking at the expenses and the revenues and working through that process. So we have a preliminary number we've worked through, and we know what we have some targets to hit. And so we're working through that process. And some updates for meetings that are impactful, including board members. We will have a budget and finance committee of the board meeting. I believe it's Wednesday, September 3rd. Or September 4th. one of those 2 days there. That's an additional meeting being added, and we usually meet once a month, and so we'll have that meeting. Then the following Monday is a Board of County Commissioners meeting. I believe we're tentatively on the agenda to come back and do a presentation with the commissioners. Then we'll also, on September 18th, have another Budget and Finance Committee of the Board meeting to discuss what we will present at the September Board of Health meeting. So the first full presentation of a budget proposal will be brought forth to the September meeting. We'll be able to incorporate any comments, concerns, considerations, and bring that back forth, or bring it back to the board for October Board of Health meeting, and then look for an approval at that point. Or we also can make some adjustments, and then we have a December Board of Health meeting. So we have another opportunity if we need to move it forward. Alongside the budget for 2026, we'll also be bringing forth the fee schedule related to the budget. So as part of the budget preparation, some programs that develop their fees, such as environmental public health, they work through what fees we'll be needing to cover their costs. And so I do anticipate fee increases on some of our fee schedule that we'll bring forth and show the analysis and the current fee and what the proposed fees are. So we'll be looking for that from the board as well. So because we did postpone or push out the July Board of Health meeting to today, the financials today are on June as opposed to July. And so I'm a bit of a broken record. I always mention about our indirect federal grants and our state grants. We do pay in advance, so we pay all our expenses, and then we run our month-end reports, and then we bill to the funder for reimbursement. So we do need to have a healthy reserve in order to do that. And so you'll see in the month of June, we've only calculated $20,000 for indirect federal grants, and then we actually have an adjustment here for state. So we're looking at approximately at least $2 million that we have not billed. So the bottom line of the $1.6 million a year to date, showing a deficit or a draw from fund balance. That's a temporary time slot because we have not invoiced for those expenditures for reimbursement. We also have 3 categories that funding that does come in advance of billing, or we don't have to bill for, and that would be the Foundational Public Health Services funding, and we get that every July and January. So we're looking for there'll be at least a $3 million deposit into our account in July, and that will be reflected in next month's report. Also, the public health appropriations that we get from the state of Washington also comes every January and July. So we'll have a July payment of $1.4 million that will also be hitting our books. And then, of course, we'll be hitting third quarter starting July 1. So we'll be invoicing Spokane County for the third quarter county assessment. So those are still all pending items. And so reflecting, even though we have a deficit at this point of 1.6, if I move on to our reserve balance, and I'll mention also our expenses year to date are 45%, and we would be at 50% of the year. So we're running a little lower on our expenses, and then we're at 42% for our revenue. So half a year we'd be at 50 as a target. And then this last slide is related to the reserve balance. And even with a deficit through the month of June, we still are at a 21% reserve balance in the unassigned. And then, of course, we have our board emergency of the 1.5 and the assigned reserves of 4.8 million. So our total reserves was 18.2. And I did some calculations from the prior discussion with Dr. Thompson. So just to share related to our discretionary funding. So there are 3 funding streams. The state of Washington funding we call local government assistance, LGA. That number is $2,877,318. And that is been stagnant for 15 plus years. It's the replacement of the motor vehicle excise tax funds. So that's one of our funding streams that comes every July and January. And then also the FPHS, the reinforcing capacity component, It's flexible for flexible for reinforcing capacity FPHS funds, meaning we can't use it for WIC. WIC is an additional important service according to the state, and not a foundational public health service. So it is flexible for most of our programs, but not all. And that is $2,095,000. And that is also projected to be the same number in 26 as it is in 25. We did have a reduction in the categorical FPHS funding, and we were able to, as an organization, put in the request of where we could make that reduction, which was very helpful because we did have 3 categories that were chronically underspent because they were so categorical, we couldn't spend them. We didn't have the activities. And so we took the reduction there. And then to answer your question, Commissioner, is in 2026, the allocation to the health district was the $2,053,960. So collectively, that would be the $7,026,000. And that's 30% for the contributions, 30% roughly from the county, 30% from the reinforcing capacity, FPHS, and 40% from the state. And that makes up the 11% of our total $57 million budget. And so of the 11%, to answer that question, 3.2% would be from Spokane County's contribution, and then 4.5% from the state, and 3.3% on the reinforcing capacity FPHS. And we're projecting to be, again, around the $57 million budget. Even though we've had reductions, we do have the state special education funding, which is pass-through dollars. And so that is showing an increase. So even though we've gone down in some of our programs, we'll probably be similar in the overall budget.
Thank you.
You're welcome. Any other questions?
Any other questions for Kim? Okay, thanks, Kim.
You're welcome.
And next, we have our health officer, Dr. V.
Good morning, everyone. So I just have a couple of updates, and won't take long because I don't want us to wait for the topic that Naji has for us, which is always really interesting. But I have a few things I want to share with you today. First thing is we probably have all heard about chikungunya in the news for a variety of reasons. So I want to give you a little bit of a review. We talked about it a couple of years ago, but this is a disease that is transmitted by mosquito bites, and has made the news for a variety of reasons in the last couple of months, and I'll talk about that in a second. The name is kind of interesting because it basically comes from the Kimakonde, which is a Makando people language, which means bent over. And I'll show you a picture of that. You probably have seen this, a lot of the wood carvings of this particular folks that are very, very exciting. But it's something that we've known since the 50s. It's not a new disease. I heard somewhere we have a new disease floating. I said, actually, no, it's older than I am, and that means it's very old. And I meant that in a very nice way, of course. But since 2004, since we started counting, we had a whole bunch of outbreaks in various parts of the world, over 100 countries, including in North and South America. Just because the mosquitoes have adapted, have traveled with global travel, these things move. You do need the mosquito, and you do need the virus in the same place at the same time. We have seen in some islands in which there's high immunity. As a general rule, if you have disease, typically after that you have lifelong immunity. Not true of immunizations, and I'm going to talk about that in a second. But it's transmitted on the bite, usually during the day. And I will show you a graphic that has the life cycle of the virus, which is a little bit easier to look than this. But the issue is mosquitoes have to have access to a host that has the virus for the mosquito to actually ingest the virus, replicate in the salivary glands, and then transmit to another human. There's no other way of passing. The reason why I mention that is because I saw in one of the news a question about what happens if somebody coughs on you. Well, not gonna get it. It's not transmitted that way. It's only transmitted by mosquito bites, and this is the way it goes. So the mosquito will get the virus, goes into the host gets sick, Typically, you have a lot of aches and pains, which is the reason why people double over. About 40% of the patients go into a chronic phase, and the chronic phase is arthralgias and joint pain. So you feel like you're 100 years old, even if you're 30. And one of the things that we do know, this is the picture that gave it its name, that contorted posture that we see. But one of the issues that is important to remember is that many of these patients will go into a chronic phase that can last months or years, and is reoccurring arthralgias and pains in the joints. One of the concerns is the potential for involvement of either the central or the peripheral nervous system. This is a breakdown of frequency for adults and children. The most common is what is called altered consciousness. People are a little bit out of it and have headaches. Kids, you can have seizures. One of the concerns is Guillain-Barré syndrome. As you know, that is when your immune system attacks your peripheral nervous system and you can have respiratory paralysis. The treatment for that, there's a lot of treatments for that. I remember taking care of patients with Guillain-Barré back in my clinical days. We're doing apheresis, plasma exchange. Basically, you take the plasma out, clean it out, and give it back to them. It's quite an impressive process, takes many hours. So right now, there are several travel advisories, and this is the important thing to remember from this presentation. These are the countries in which we have documented outbreaks. Actually, I think Brazil is going to come on this column pretty soon. There are about 240,000 cases reported thus far, up to July, globally. This area made the news, the Guangdong province in China. There's about 7,000 cases. There's about 185,000 in Brazil, just to give you some perspective. So Brazil, Argentina, and a whole bunch of the places that are south of us, we do see a lot of cases. So those are travel advisories. If you're going to travel, talk to your provider, make sure that you have access to the immunization if it's necessary. There's 2 vaccines that are available in the US. One is the attenuated virus, and the other one is man-made protein that actually acts like a virus and generates an immune response. They're both available, fairly expensive, but your provider can prescribe those if you're going to go into one of the high-risk areas or one of the areas in which there's a known outbreak. We do see occasional cases in the US every year, typically related to some travel, just because we don't have the same prevalence of the virus here. So I'm going to move on from chikungunya and talk about a couple of other things. And one of the areas that I've been sending people to look at is if you go on our website, you will see a section of advisories that have alerts. And if you look down here, we've always had human health. Now we also have animal health. We'll be working very closely with our veterinary partners on a number of issues, which is great to know. So this is, as of last week, because this presentation was put together last week because we had turned it in so you can have it. Otherwise, you can't get it ahead of time. Otherwise, the top one will not have been that case in Kootenai County. It will have been the news release from yesterday that we do have a diagnosed case of measles in Spokane County, which we sent a press release yesterday. So we do have a patient that has been diagnosed, and we do know that there were some potential exposures between August the 12th and August the 15th at least 2 or 3 locations. And we put those on the website so people can take a look at it. So the reason I bring that up is because if we were here last week, we'll have talked about this case, which we alerted our providers to make sure everybody knew that there were cases across the border from us. But if we were having the same conversation today, I will tell you we're looking at cases here. So it's a little bit early to tell what's going to happen. The whole team has been working with our healthcare partners. So we're on the alert. We're like we were last year when there was a concern. So we'll circle back to you with information as that becomes available. But this was the news last week. Now, overall in the country, just as a reminder, we've had thousands of cases in most states. I think we're going to have to add Spokane to that list. And it's not something that is unheard of, as you can tell. It's been reported by most jurisdictions in the U.S. So it's something to be aware of. We do know that immunization is critical for that. This is the breakdown of the cases. Youth and young adult compose the vast majority of those. Unfortunately, we had 3 deaths confirmed thus far. Don't forget that measles can be lethal for those that are at higher risk. And I can tell you that in Spokane County, if you look at our age group 4 to 6, which is a prime group where we want to see a lot of immunizations, 95% or higher, we're running about 69%. So we got a little bit of work to do to come up with that. So make sure that we're all aware of that. Now, last week we alerted everyone to the potential exposure at Eastern State Hospital on tuberculosis. It made the news. I do want to say thank you to our partners at Eastern and also to the TV team here, Katie and the team, because they've been doing a great job on doing all of the disease investigation that goes along with this. One of the things we tend to forget, we think about the person that is being treated, but we forget about all of the people that may have been exposed and need to be tested and ruled out. And for this particular case, we're talking about hundreds. So each TB case can actually ripple through tens or hundreds of people, depending on where it happens. And it's part of the work that if this was here, that the TB team will do here. And we've been working with Eastern, so I want to say thank you to them because they've done a great job thus far in making sure everybody's being tested. So one of the things that we added in this year is animal health. And in the latest one that we have, which didn't make it to the website by the time I publish this, we reminded all of our veterinary friends about transmission pets, bats and pets. And the reason for that is because we continue to hear a lot about bats. And as you know, we did have a rabbit bat, and we may have another one, but bats and pets tend to play together, and it's not a good thing. So a reminder to everyone, if you see a bat, leave it alone. If it's not bothering you, just don't bother it. Now, it varies by species, and our veterinary friends are really good at it, but if you do have an animal that has been exposed to a bat, please consult your veterinarian, and they'll be able to provide you direction. All of this information is on our website. So if you want to find all of this, go to our website and look under the advisories, and you will see both human and animal health. And as a general member of the community, you can have access to that information. Now, community collaboration is changing gears a little bit. This is the latest issue of the Spokane County Medical Society Journal, which is called Messages. And we had a great article by Alicia Kreitzer from our Nurse Family Partnership, providing our providers with a little bit of context of what the program is. As you know, this is a program for first-time moms that does a great job of partnering a nurse with the mom. And as you know, babies don't come with procedure manuals. So for first-time moms, that's actually a very useful partnership. This person becomes not only a healthcare advisor, but basically a partner and a general advisor for the individual, also connects them with any other services that may be needed. And if you talk to the moms that have been part of this, they rave about the program. So I just want to say thank you to Alicia. We managed to also weave in her busy schedule a whole bunch of presentations through medical staffs of various locations. So now, one of our members of our team, and I have a full report that is very comprehensive, we'll do it not today, is on lead. Caveat, lead typically action is required at 5 micrograms per deciliter, meaning we get into action. That number is going down to about 3.5 statewide. And what that basically means is if you look at 2024, the dark color are those that were 5 and over. The orangey circle are those that will have been action if we had a 3.5, and these are the ones that are lower. So the bottom line on that one, and this is a very busy slide, in 2024, that means we will have had to take action on another 253 cases, which is about 2.5 times what we had. So the volume of cases that we're going to intervene with is going to go up significantly when we see these numbers. And that also tells us that we still have a lot of lead in the community. And if you recall, Jenny Horeshny and I wrote an article in the same County Medical Society about lead in children. So with that, I'm going to stop here and see if you have any questions. And don't confuse chikungunya with Orobush. We talked about it earlier this year. 2 different viruses.
Go ahead.
Yeah, just on that, just curious, is that disease spreading kind of everywhere in those countries? Is it predominantly in more rural areas, like in Thailand, like Japanese encephalitis?
Yeah, it's actually
only in those
fairly
areas?
fairly broad spread because of the mosquitoes. In China, right now is somewhat centralized in one large province. That may also have to do with isolation. It can be isolated, but in heavily populated countries, tends to spread through the population. Obviously, in areas in which you have rural environments, we have more water that tends to sit, which is what the mosquitoes need to lay their eggs. So it varies.
Okay.
Yeah. But there are great advisories from the Pan American Health Organization, WHO, and the CDC. If you're going to travel somewhere, you can actually narrow it down by city. Good question. So, any other questions?
Dr. V, the blood lead levels, it's concerning that they've doubled the high range, right? But it also looks like because it's more, are we testing more? We're testing more people,
Yeah.
children. So is that a active, is there a new guidance that pediatricians should be testing that like more frequently?
So that's a good question. And when we come back with a full report, you will see precisely what you just said, which is we have an increase in testing. And the increase in testing is because of the awareness and the knowledge. So I want to give the team here kudos on that, but also kudos to our pediatricians and others that take care of children, because we have seen a lot of increase in the testing itself, which is what we need. So the interesting thing is that the more we test, the more likely that we're going to find a lot more in that 3.5 and above. But that is okay, because that allows us to then zero in on what is the cause. What's the causative effect? Is it in the land? Is it in the food? Is it in the cooking utensils and so on and so forth? Remember that some of the cooking products, like pots and pans, some of them that are used traditionally in many cultures do have a high lead content. And we've been trying to replace those with traditional stainless steel cooking appliances. So we'll come back to you with a big report. It's like 23 pages, a lot of detail. And Jenny did an amazing report, but I want to give you the highlights because you're going to hear about this change. So I didn't want you to be surprised when you see that the number all of a sudden went sky high. Any other questions? Thank you.
Thank you. All right, going back to our agenda, we have a little update on our cybersecurity program here, trying to keep our systems safe.
Thanks for that introduction. It's a privilege to be here in front of the board again, and I'm reminded when I see Dr. V here that while technology seems complicated, it's not nearly as complicated as the chikungunya virus or lead surveillance and yeah, it's so I'm also inspired by the treatment services people here. I'll take technology over any day over some of the things I hear they work with. So privileged to be here. Just a little backstory about me. So a long time ago, I was in a class in college, and one of the professors said, "Hey, you're all students here. You should know why you should listen to me." Different setting, but my name's Naji Seyhanlı. I have a Turkish background, although I'm from the Northwest. I've been here since 2008. I'm still fortunate. I'm very fortunate to be here in 2008. I was kind of the AV geek for a long time, worked my way into IT, and then for the last 3 years or so, I've been the IT security analyst here in the IT program. So there are 7 of us, a couple colleagues are here with me. I couldn't be happier to be here. It's a privilege again to work with them and be in front of you today. And can't really express how much they contribute to the IT program and the wonderful technology we've got here, as well as the security. And of course, the support from administration, Dr. Velasquez and Dr. Thompson has been invaluable. So thanks for this time, Dr. V. I can assure you, you're not old. I just wanted to point that out again. And thank you for the extra time. I've got 50 or 60 slides here to go through. I kid. So yeah, we are the IT program. Again, 7 people. I'm the only IT security analyst, but we work really collaboratively together. It's truly a team effort. It's a super big privilege to be here and be in my position. As far as AT goes, you'll notice some of my slides are simplistic compared to what you've seen here earlier today. That's the way I think, and it's served me well. I'm still alive, so I'll keep that going. We focus on, at least I do, and I should say we focus on 3 three major efforts here in IT. We've got organized by a funny icon here, ransomware slash malware, phishing attacks, and data breaches. I should add that the fun walking off document there on the right it should be data loss too. We think of data breaches as people stealing things often, but these days it's not so much a breach as someone doing something accidentally and our data maybe making it into the wild unintentionally. So should be a data loss there as well. It's not always malicious. Some bad person outside. I'll go pretty quick here too. I won't belabor a lot of this. But if you got questions at the end, just let me know. Just a little bit of backstory from last year. The FBI Internet Crime Report comes out every year, and we're there in the top 10 with states by the most money lost. I should note that the public health medical sector is one of the most hard hit when it comes to losses from cybercrime and cyber attacks. So we're in that category as well as Washington. So we're kind of high profile when it comes to the amount of money that's lost. If we look on the right, we can kind of break it down a little bit. Business email compromise, that's where Dr. Velasquez, Dr. Thompson come in. People posing as them, people posing maybe as a contractor. I know our finance people, are really everyone here at the health district is well aware. Posing as a vendor, posing as a contractor, asking for money. And then the victim coughs it up. That's a big, and you know this, you've probably seen email coming asking for money. That's a big factor in losses. Data breaches, of course, we have to pay out. You know, if for some reason our valuable EPHI or valuable data gets exposed, credit card, check fraud is kind of self-evident. Ransomware, that's where your stuff gets locked up and you got to pay. We don't pay. People shouldn't pay to get their documentation back. They should have practices in place. And then malware. So it's not good that we're on the list there as far as the top 10 states paying out, but that's what it is. So it's a big deal because, aside from the payout, we spend a lot of time cleaning up. We don't want to do that. So we'd rather put our eggs in the prevention basket. As far as prevention goes, I think that's the most important place to start. When we can create a culture that prevents the bad stuff from happening, that's where, we kind of block, we put the wall up. If we can stop the bad stuff, we save money, we save time, the bad stuff doesn't happen. And we do that in IT with knowledge. I'd probably fit in that little armor, that little guy's armor there. But it's a representation of the efforts we make. The three on the right are just a few of the efforts we make. We contracted with a local company called Drip 7. They make what's kind of, I think, a novel product. It's a cybersecurity awareness app. So every day we hop on the internet and answer a question or two, become more, all employees should do this. I recommend for all those watching on YouTube or later on our website, participate in Drip 7. So log on, it's easy to access. You learn a little bit about cyber security and security in general. You can take it home, the knowledge home, put it into practice there. And so it's just daily participation, and it's been really great. We continue to develop with them. We were one of their first clients, and so that's just one piece of the education puzzle. The other is something that we all develop in IT called the IT Corner. It's a mostly monthly 15 to 30 minute video that highlights a specific IT/security topic. Spoiler alert, tomorrow's episode comes out. We'll be highlighting some technology that's going on in the environmental public health program. So we keep in contact that way too. We like to kind of spread out our communication methods. And then whenever there's anything emerging, we send out an email letting people know a maintenance issue, a security issue. We're always in contact that way too. Of course, we've got help desk. We've got all the rest of the stuff that you would expect. But knowledge is really where we start. If we can start there, you know this. I mean, we wouldn't send, well, maybe some people send a teenager out there in a car without learning how to drive it, but that's not a good idea. And we don't want to put technology in our employees' hands without them kind of knowing how to use it safely. So let's start. You remember the little phishing envelope icon? That's kind of the vector, right? Like if we're going back to a medical analogy, the email is the vector for the disease. I won't be sneezing on anyone or standing around mosquitoes during the meeting, but email is the place where we want to start because that's where the bad guys come through predominantly still. And so we have practices in place. We have multi-factor authentication. If you're at the county or the city, you probably got to enter a text, use your authenticator app, answer a call. So we've got that in place. You'd be surprised how many people don't. It's kind of shocking. They're just a password and a username and you're in. That's not cool. We have conditional access policies on the email. So if you're outside the country, you can't get in. If you've got a device that's not one of ours, you can't get in. And we're going to be locking things down further. Once we've authenticated you and you're okay to get in, then we have controls. And I should back up and say that we're a heavily influenced Microsoft organization. We have a lot of eggs, I think for a good reason, in the Microsoft basket from a application, operating system, and security standpoint. We use a lot of their products heavily. So a lot of these things you're seeing here are coming from the Microsoft Security Administration end. So once you're into your email, we protect it. We don't just let anything come through your email. You got a bad attachment, we'll find it. If it's a spammy attachment, we'll find it. If there are a lot of things, we'll find it, hopefully, and generally we do. Once it makes it into your inbox and we examine it further, is there some manipulation going on once it's in your box, in your email box? We can look at it there and we can mitigate things there. But email that's the place. So I encourage you, if at home, at work, wherever you are, watch your email. Don't be cavalier about just letting anything through or answering anything. That's the vector still. We move on to Purview. That's where that's where our data loss guy, there goes our file out into the wild. Bye-bye, little buddy. We use a product called Purview to prevent that data loss. We can inspect who's doing what. Is it HIPAA information? Is it financial information? We can see that coming and going. We put policies into place that actually inspect it, control it. From there, we move on to insider risk management. Is someone trying to, we haven't seen this yet, but are they trying to exfiltrate information? Are they trying to share stuff they shouldn't be? So we can look for indicators of compromise there. And let's say something bad does happen, or we have questions about what's happening. We have products that can go back and look at who did what to when, where, all that information. We can back into it and examine that from an audit perspective, and that's all on the data side. This is something we continuously develop because, as you can imagine, there are much larger organizations than ours that use a much heavier tool set with a lot more people. So the ability is there for us, and we're continuing to take advantage of it. Finally, it's your device, your phone, your Surface, your computer, whatever it is. That's where we inspect that too, because your account's not just your email. Your account is also your username. So if somebody can get a hold of that and they're on your device, bad things can happen. So is it you? Is your Windows operating system updated? Are your applications updated? Are your applications vulnerable? Is it configured right? Is it you on your account, on your computer? Is somebody else in there? And then what are people using? Are they risky? Should we allow them to do that? So just to back up, we've got email, we've got the data, and now we've got the endpoint. It's kind of the holy trinity, if we look at it that way. So how do we know how do we know if we're doing what we should be doing? How do we know if everything's working? We don't. There's always something out there we don't know, but we take really good guesses at it, educated guesses, we learn, and provide feedback from each other. We welcome feedback from everybody else here in the room and throughout the building. But what we can do is we can look at metrics, and Microsoft gives us those too. And these are generally widely, credibly accepted metrics. They have what's called a secure score. So the secure score looks at your account, so your identity, your device, your data. It looks at 4 key components. And let's see, I had those handy real quick, but it looks at all those components and your security controls around them and gives you a score, kind of like your report card. And our report card is pretty good. You can see our secure score. This has actually gone up in the last couple months because we haven't talked since June, but it's gone up a couple points. Our secure score is 76%. And if you look on the right, our score is much higher than organizations of a similar size. And that's accurate. Those are health organizations of our size using our products. So the kind of the metrics there are identities, data, device, and apps. So it looks at applications too. What are you using on what device with what accounts? And so our score is much higher. And you can see in the middle, a good secure score is around 68, 80%. So we're right there in the middle. But we keep moving because we like goodwill among all of you very collaborative, helpful people in government, and we don't want to outlive that welcome. We want to be here safe, not exposed, not in the paper, continue to do the right thing so that you're all free to do your work. So what's next for us? More of the same generally. We'll continue to secure our devices and our identities. There's always work to be done. And the image of an onion over there is something that's used in security a lot. The layers in an onion are kind of roundabout way to think of security. You know, you get through one layer, or doors, right? Doors in a room. You get through one lock, but can you get through all the locks? You know, so we've got layers of security that we layer on, and then we make those layers tougher. So we'll continue to secure the devices so that maybe if you're roaming out there in a place we don't want you to be, it won't work. Or your account, you know, your phone won't work there. If it's not up to date, it won't work. So we'll continue to secure those devices and your identities. Our network's huge, but we don't want people in our network. Once they got through that last door and they're into our network, you know, they can start to move around. We're going to stop that. And we do. We limit it, but we'll continue to make that more resilient and secure. Outreach, I think, like I started, is the most important part. You know, if we can, you know, impart a culture of security here and let people know that, hey, don't do bad stuff because it makes things bad for everybody, I think that's helpful. So we'll continue to create that outreach through cybersecurity education, communication, and collaboration. And one thing that I think goes unnoticed a lot, that I didn't notice a lot when I first started working in this capacity and really in IT, is how important policies and procedures are. When we have standardized policies and procedures, we can really lock down how we secure devices, how we communicate with people, how we remediate problems. It leaves out all that variability and confusion when something gets touched by different hands. So I think having standardization in policies and procedures is a fantastic thing that can really supplement our security here. So with that, I will cede my time. Thank you again for having me here and the invitation. It's a real privilege, and just couldn't say enough about our team and everybody from our team who's not here. So thanks to them too.
Thanks, Najee.
Yeah,
Is there
any
any
questions?
other questions? Or I like simple, so I love your little.
Yeah, simple works for me. That's my mind in general. Thank you.
Appreciate that. Oh,
Yeah.
yes, Commissioner Kuhn.
So I will just say it is so important. So we just had my assistant, she got, I don't know, some kind of email hacked that went out, but used like a Comcast, you know.
Yeah, really believable, right?
Yes. So, you know, which he doesn't use Comcast. So,
Yeah.
So no, it's really important what you're doing. And
Thank you very much.
so.
Yeah,
thank
just
you.
there crazy examples. I was in communication with somebody at Okanagan County about a year ago, and there was funny email coming from them, and so I just decided one thing you can really do is just call, right? Like, hey, is this you sending this? Is this something you recognize? And she's like, I'm glad you called because we had a contractor we're working with, and they got hacked, and they started using their letterhead and got a hold of their email and started trying to skim money off of us. And she broke down the whole. This went on for a month, but it could have been ameliorated by just with a phone call, you know, or just a little inspection. So, you know, 5 minutes of time can save millions of dollars probably. But yeah, so just, yeah, you're doing the right thing. I encourage everybody to keep doing the right thing. Thanks again.
Thank you. All right. Well, we have about a half an hour left till noon. I know that some of us are going to be attending the memorial service, which starts a little later, but some people have to get there. Commissioner Cuny, do you have to get there a little earlier?
I do. I'm delivering the proclamation that we did to the family ahead of the service.
Okay. So I'm just wondering if we want to take our action items first in case, or just stick on the schedule with the exec session. So how many minutes are we expecting, Michelle, for the executive session? Okay, as long as we have, if folks do have to leave at noon, but as long as we have a quorum to be able to take action on our action items, if we have to go a little over noon, just getting the pulse of the group here.
So the action item shouldn't take very long, right?
Well, that's why I was suggesting
Yeah.
just getting those done.
I think we can, because then I could, if I need to be on a phone, just on a speakerphone with somebody if I need to for the rest of the executive session. Maybe not.
Okay, let's do the action items. That's what I was suggesting. Sorry, Michelle, you've been overruled. It's okay. So if we can move to 8, we have election of the Board of Health Vice Chair. So we were without a vice chair for a little while, and we have to do another election.
I move that we appoint Michael Cathcart to be the vice chair of the Board of Health. Again.
Do I have a second?
Second. Oh, Patricia seconded.
Okay, so motion is second, and just for history, Liz, is that Councilmember Cathcart was our vice chair for this whole year. Then with the change in the board composition, his seat was removed, and now it's back with the new Kalispell Tribe appointment. So he was serving in the vice chair role, and so we have a motion and a second to put him back in the vice chair role. Any discussion on the motion? Okay, seeing none, all in favor say aye. Aye. Any opposed? Okay, Monica, is that an aye from you? I'm assuming?
Aye.
Okay, just since I didn't hear opposed. Okay, so unanimously, congratulations, back as vice chair, Councilmember Cathcart. And then we have our second action item, and this is that the bylaws update that we mentioned earlier in the meeting related to the new rules at the state around Board of Health membership. So Michelle, just a quick overview.
Yep. So as we discussed, the county commissioners passed their resolution. I took that information, used it to create the bylaw changes for the health district. The only exception to that is the information we got last Thursday that the Washington State Department of Health views the proper entity to notify the Indian Health Commission to be this Board of Health. So I made that revision as well. But otherwise, it tracks with what the county resolution is.
County resolution, we had put that it was the tribe that notified, but actually in the RCW, it's the Board of Health that notifies. So this reflects is the current RCW, which the WAC may tighten this up or give slightly different guidance. So we can adjust it down the road, correct?
Correct.
The rules if we have other guidance from the state.
Right.
Okay. Yes, Councilmember Cathcart.
Yeah, I will so move adoption of the amended SRHD Board of Health bylaws as presented under 8B.
Second.
Okay, motion and second. Any discussion on the motion? Oh, yes, Michelle.
My apologies. Normally, the bylaws are a 2-touch rule, but there is a provision that they can be done on a 1-touch with essentially a supermajority. So just so everybody's aware of that.
Okay. And I think we were trying to get it done to be in line with the new state law and the county commissioner resolution. So so we just need a supermajority to approve the bylaws changes. Okay. If there's no further discussion, seeing none, all in favor of approving the amending our Board of Health bylaws to update the membership, please say aye.
Aye.
Aye. Any opposed? Oh, I got a thumbs up from Dr. Malkowski May. Okay, so unanimously we've approved the new bylaws. So thank you, Michelle, for working on those and working through all the nuances. Appreciate that. All right, so we're going to go into executive session. And Michelle, if you could just state for the record the purpose of the executive session or purposes.
Pursuant to RCW 4231-10-1I, and also to review performance of a public employee under 4231-10-1G. Present will be the board members of legal counsel, and I anticipate 30 minutes to start. Time constraints. 30 minutes. Okay.
Thank you. We'll just take a couple minutes to clear the room and then we'll get started. Thank you. And so for the purposes of this, Anne, what do we need to do to make sure Dr. Blakowski May can just speak into the mic or so she can hear us?
I can hear you now.
So I'm going to test without the mic and just see. So I'm on the mic right now. Okay, now I'm just speaking to you normally. Can you hear me now?
Yeah, I could hear you just say, I heard you now. I can hear you. Can I hear you now? I just heard that.
Okay, but did you hear me speaking when I wasn't on the mic prior to that?
I don't
No.
think so.
Okay, all right. So we'll just, maybe we can just turn down the mics a little bit.
Yeah, so.
Okay. But we do need to just speak into the mic so she can hear. Okay.
Dr. May, can you hear me right now?
I don't, Josh, if that was you trying to say something in the, I couldn't really hear you. I just saw your lips move.
All right, we're going to use the mics, doctor. Okay. They are a little loud. we're back in regular session, and I think the last item was just if there's any board updates. We went a little long today, so apologize for that. Sorry, let me get to my agenda. Sorry, too many papers. Okay. The board member check-in. Does anyone have any updates around the room? See none. No more citizen input, so we will adjourn as of 12:36 p.m. Thank you.